Thank you, everybody, for being patient, and thank you, all of you, for participating in this question and answer session. We are running a little bit late, so we are going to compress the question and answer session from 20 minutes to 15 minutes. So we are going to finish approximately at 2:55. But again, thank you to all of you, our speakers, for being available for this virtual symposium. Acute flaccid myelitis is becoming a very important topic in the past 10 years. COVID-19 is pushing now the interest on enteroviruses, D60A, a little bit to the side, but we are focused and we are going to continue our effort to understand acute flaccid myelitis. And I appreciate the work that you are doing in the labs and everything that you are doing for understanding AFM. I have a question. I am a clinical neurologist, and I always like to ask my colleagues who are working on the bench about a very critical question, and this is a question for all of you, is why enterovirus D68 targets only and exclusively motor neurons in the spinal cord. We have motor neurons in the cerebral cortex, but only the cranial nerve motor neurons and only the spinal cord motor neurons are targeted, at least in function. We heard from you, Amy, about astrocytes, but if that's the situation, what happened in the human spinal cord? There are astrocytes everywhere. What happened? So the question is, what is your view why enterovirus D68 is so selective in spinal cord motor neurons? And Amy, so let's go and start with you.
So I feel more along the lines of that you see motor neuron death because that's the phenotype that we're looking at. But there are a lot of times when it's not completely lethal to the cell, and the cells recover, as like Ben described last week. And Sabin and Richard Johnson have all characterized this well for polio and other neurotropic viruses, where we really see a very specific subtype when you're looking at the lethal form or the most extreme form of the disease, and then we're missing all the other cells that can be infected. And I think that this really comes down to something that Sabin once pointed out to a lot of molecular virologists, is that neuroattenuation, neurovirulence, neurophenotype, attenuated phenotypes, they all have a very specific definition that we in the lab kind of it's easiest to look at the most extreme phenotypes and make a lump statement, and that we miss the subtleties of how different cells respond to virus. And I think that that's what we're saying, is that we're missing that subtlety.
Thank you, Amy. Bill?
Well, I think, we really study, we do exactly what Sabin said we shouldn't do, is my lab is studying the simplest models. And I don't know whether it's really the type of cell or whether it's the access to those cells, or whether, as Amy said, we're looking at the extreme phenotypes. We're seeing the kids who come in with a full paralysis, when we maybe aren't seeing more subtle phenotypes show up in the clinic, or at least show up in the clinic where somebody would test for EVD68.
Thank you, Bill. Richard?
I guess I would defer to Ken and Amy, who have kind of direct experience in terms of which cells are being infected. But, it doesn't surprise me that there are very specific receptors that are being used by the virus that are differentially expressed in different neuron types. I think that remains to be well characterized at this point, but I suspect that there's a relationship between the receptors that are being expressed and which cells are able to be infected.
I don't think it's a receptor problem. You don't see a receptor difference for polio. you see a downstream downstream host factor, like whether or not it's for translation, for viral application, for packing, for assembly of the capsid, for egress. It's not a receptor issue. It's a problem of what terminally differentiates an astrocyte from a lung epithelial cell, and that program defines how cells respond.
Hey, this is Ken. My guess is that it's probably multifactorial. I'm impressed with the point a little bit that William made, that when we inoculate mice, for example, intramuscularly, that's a super efficient way of getting paralysis, which suggests that, access and targeting is actually part of the issue. And I think, as Amy eloquently showed, things like host factors are obviously going to be critical too, likely involving innate immune responses. And I may be not as definitive as Amy is about whether or not receptor utilization could also be part of that mix, because in our hands there are some differences between the way the ancestral strains, which are not paralytic in mice, and the modern strains, which are, seem to depend on things like sialic acids and other things to enter cells. So I have a little bit more of the jury still out of the receptor part, but I absolutely would agree with Amy and Bill that the story is likely to involve access, host factors, including those involved in innate immunity. But I'm not taking receptors off the table either.
Thank you.
I'm not saying that it couldn't factor in. I'm just saying historically, even if you look at rhino, it has three different receptors and it all targets the same cell. And historically, picornas don't have different receptors at the sites of initial infection and in the central nervous system. Yeah.
And the only observation I would make is that if we used historical evidence to understand new viruses, we would have made stunning mistakes in Zika. We would have made some very interesting mistakes in coronavirus. So history is interesting and informative, but tells us absolutely nothing about enterovirus D68 and its actual performance. It just gives us a framework to consider.
Right. It's a framework that we work within.
Yeah, absolutely. And Amy and I totally agree on that.
So I was very fascinated with the Bill work on the ultrastructure and what you show in terms of electron microscopy. And I think that the audience was very curious about that. There are several questions. There are two questions for you here from the audience. One is regarding the acidification of vesicles during egress. Were those experiments done with ED68? That's a question. And the second question is actually in the same reliance on autophagy and acidification of vesicle in both historic strains in the 60s and more recent strains. I mean, are there differences? So those are the two questions for you.
Absolutely. We've done most of our work with the Fermont strain so far. We certainly have more modern strains, but in my lab, we'll only work with virus that we produce from a cDNA. So we're now getting those cDNAs and collecting them because we just don't want accumulated mutations to drive us away from the original virus. So the cDNA we had first was Fermont. So most of those experiments were done with Fermont. We've replicated much of what we did with poliovirus with EVD68. Some of those experiments are very difficult. We haven't gone back and done everything, so we don't know the precise nature of, for example, the VP0, VP24 cleavage. I think those are experiments we should do. We should go back and do, in particular, in that it's very difficult to sell a postdoc on, can you repeat this for me, when they want to do the new experiment. So I'm going to force somebody and chain them to the bench until we get all of those things repeated cleanly.
Great. Thank you so much, Bill. Richard, it's very fascinating to see all of these phylogenetic trees. But for many of the clinical people, we like to understand, for example, in the scenario of different countries, what is going on with enterovirus circulation and enterovirus mutations, etc. you outlined 4 different points for the potential drivers, and I'm very curious to see if you briefly outline why we are experiencing this in the United States, and we are not seeing too much in other countries like, let's say, Europe, or we are not seeing this in Asia, we are not seeing this in Latin America. Do you mind explaining briefly about that?
Mm-hmm. Yeah, well, obviously this is speculation, but although we do see that there's kind of broad distribution of different clades around the world, there are some kind of enrichments that we're seeing. So, I mentioned that the B2 clade is found predominantly in Europe, and the D clade is found predominantly in Europe and in Asia. And if you actually look, the currently circulating strains seem to be either B3 or D. So it could be that, because of founder effects, that, the predominant D68s that are circulating in Europe and in Asia are part of the D clade, which may not have the same kinds of characteristics as B3. So, I think it's very tricky to be able to kind of integrate founder effects with drivers of evolution and how that kind of those two things together give rise to the phylogenetic patterns that we're seeing. But I think that's one possibility.
Great. Thank you, Richard. So this is a question for all of you. And I will start with Amy and Ken first. And I'd like to Bill and Richard give opinion about this. But the main question is, we are eager to get treatments, and you are developing these models, and these are very good models. And between the viral entry, the pathogenesis in the cell to the outcome that is paralysis, we have a very narrow period of time. We have hours. So obviously we have a priority either on developing a strong therapies to halt and stop the process of neuronal damage and recovery. So how we can help to understand, or how can we identify these therapies? I mean, you already outlined in your models that approach, but what is the priority and how we are going to achieve, and what would be the best approach to avoid progression of paralysis? I don't believe that we are going to stop the process of infection. It's too late when we detect these patients in the emergency department. So we have these models. Please help us to understand how we can find the best treatment approach for AFM.
Hey, this is Ken. Maybe I'll start and then flip it over to Amy. I think one of the hard things is at the moment, unless we suddenly see huge increases in number of cases, that the idea that we're going to be able to do our classic randomized controlled multi-center trials in kids and things like that is probably just not practicable. And we've already seen that it's hard even to let people do whatever they think is the best therapy and then try to randomly see a signal in that, as Kevin Nezikar and others tried to do with the fluoxetine approaches. So I think we're going to, for the antivirals, be in a situation where we're going to start with agents that inhibit replication in a cell culture model. And the interesting discussion would be, does adding some form of neuronal cell culture model contribute to what you learn in non-neuronal cells? And I think because we do have these mouse models, if you gave me the choice between 2 drugs, both of which inhibited in culture and one of which seemed to reduce infection in mice, I'd be picking that one, just not that mice are humans, but just that it gets us a little further along. And I may be a little more optimistic than Carlos because in our models, we do find situations, so far mostly with immune therapies like IVIG or mouse chimeric monoclonals, where treatment can begin, not within hours after inoculation, but actually after mice have developed what I would call the onset of clinical weakness, and you still see an impact. So maybe I'm more optimistic a little bit than Carlos would be. And I suspect we may be at a point. The other thing is that, remember, passive transfer of antibody, if that's indeed how these are working, which they probably are, could be used in prophylactic models as well as therapeutic models to get one across a relatively short susceptibility season. But ultimately, vaccines are going to be the driver for prevention. We don't do great with polio because we came up with a great polio treatment drug. We do great with polio because we came up with a vaccines that prevent it.
Amy?
I agree in the overall picture, but I think we're missing the beginning, and that is how the virus goes from the respiratory tract to the CNS, and whether or not the damage is really directly from viral replication within the CNS, or it's targeting, or you want an immune intervention to prevent the quote unquote cytokine immune storm that is causing the damage. And so I'm a little hesitant to hedge my bet on an antiviral and not really with concrete proof to say that it's all due to the virus. I think.
Oh, I was just going to jump in and say that I agree. And, one of the things we've learned about immunomodulatory therapies is they tend to be safe when combined with an antimicrobial agent. So, whether that's steroids and antibiotics and bacterial meningitis or TB or other settings. So, one of the nice things about having an antiviral is it may actually enable you to give immunomodulatory therapies that otherwise could worsen disease, like we saw with steroids.
So one way to look at the whole question is, can you prevent entry into the CNS? Because it's almost like, and that's where you need to target the best. And so if we understand the respiratory disease and the trafficking, then I think that's a huge leap that we can do. And that's part of our goal, is to establish a model that we can intranasally infect, and we can then ask how does it get into the CNS. And for a vaccine, I'm not, we're in a climate now because, it's COVID, and, the numbers are astronomical. It's a virus that we've never seen before. We have no advanced immunity against, and we're grasping at straws to do whatever, to have an intervention. Now, once you pass COVID, I'm not sure that the vaccine will be something that is applicable, because we have a huge bunch of anti-vaxxers and stuff. And I think almost like you need to know how to intranasally infect, how the intranasal infection occurs, because that's where you really want to target, is how it gets into. And you want to develop a vaccine that you can give as an intranasal therapy.
This is Ken, and remember, because fortunately fatalities are so rare, and when they occur tend to be long removed from the acute infection, that again, we're likely to learn those things and hope that they apply from some animal, some animal model, because the odds that you're going to be able to discover that in people is pretty slim. So another image of animal models is to at least give you some index of pathogenesis and hope that it then applies to a human situation.
And we're seeing, animal models are great. You can see it during COVID, but we have for SARS-CoV-2, but we yet don't have an animal model for the really severe forms of COVID-19 pathogenesis, the clotting, the thrombosis, the real ARDS and stuff outside of, maybe Ralph Barrick's mass-adapted virus. And so I think that we have to, keep in mind what we're working with, and with how we're going to deal with these kind of questions. And that maybe just giving lethal doses of virus is not, while it's easy in the lab to assess dead mice or not dead mice, or paralyzed mice and not paralyzed mice, we need to have something that's in between, so we can have a more faithful representation.
Bill, what is your view?
I first of all, I don't want to talk about COVID. This is the one time I don't have to talk about COVID. So let's talk about it. I think what Carlos said about that window, that tight window, that's the whole issue. And what we really need, and it's a great lead into our next talk, is we need those early diagnostics. If we can convince parents that if your child has respiratory distress, and this season that might mean a 1 in 100 chance of progressing to acute flaccid myelitis, and we have a test, then we can talk about interventions. Then we can talk about expanding that window to the point that we can actually treat the children who have EVD68 instead of just, for example, rhinovirus.
Bill, could I jump in and say, we also have models and empiric therapy with acyclovir for herpes encephalitis would be one of them, where we don't have to wait for a definitive diagnostic signal to pull the trigger. We just need a syndrome that's identifiable and a safe therapy or reasonably safe therapy. And it may be that we'll be in a similar situation here, no matter how great CSF diagnostics are.
I hope so. I mean, I hope that's the case. I just think that by the time you can specifically diagnose AFM, by the time you have, limb weakness, it's maybe beyond that window Carlos was talking about.
Absolutely.
Yeah.
Okay, Richard, you are going to end the discussion with your statement, but for the audience, in the next minute, we are going to move from the sessions to the stage to initiate with the lecture by Dr. Charlie Chu. But Richard, what is your final statement?
Yeah, I think we now have several examples of situations where severe disease seems to be associated with an over-exuberant immune response. And so, that's true for influenza. It seems to be true for enterovirus and possibly COVID-19 as well. And so I think this concept of being able to combine an antiviral with an anti-inflammatory may be a general strategy for dealing with severe viral infections. And I think it's definitely something that's worth exploring in more detail in the future.
Great. Well, thank you to all of you. Thank you, Amy. Thank you, Bill, Richard, and Ken for this effort and for your help and your extremely important work in the lab. And then we are going to move to the stage, and we are going to listen to Dr. Charles Chu and the other speakers in the rest of the virtual symposium. Please take a look and take a move to the stage. And thank you very much to all of you.